So you go into that sink and you turn off the faucet, it's like narrowing down the arteries, such as with atherosclerosis that we see with diabetics and smokers sometimes. The treatment for arterial disease involves essentially turning that faucet back on, opening those arteries back up. Fortunately, a very small proportion of the population actually requires any intervention for their arteries. And now veins, the drains. It's got to be low pressure and stay low pressure. And in our bodies, if the pressures of the veins come up, that back pressure pushes on the capillaries and pushes fluid out into the tissues that can cause symptoms such as swelling, heaviness, tired, itching, burning, pain, cramps at night, restless leg numbness. Some people have 1 or 2 symptoms, sometimes more. Only about 20% of the people with vein disease actually can see varicoses. Most varicoses lie beneath the skin surface and people are unaware of them. There's a number of reasons why people can have venous insufficiency or vein disease. The job or lifestyle is just one of them. Gender has something to do with it. Men are half as likely as women to have varicose veins, and it has a lot to do with the hormones and having babies. Family history is big. If mom or dad have bad veins, you're more likely to have bad veins. And in fact, when I see a middle-aged man with really bad veins, I'll let them know if they have any daughters to make sure to let them know that they're at much higher risk for having vein disease, and they should do conservative type things now to help preserve their veins as long as possible, including exercising, maintaining elevating the feet. Keep away from jobs where they're on their feet over 8 hours a day. Okay, so we talked about the job or lifestyle, family history, the gender, rounding off some of these others, gaining weight, getting old, injury, trauma, and surgery. In fact, anytime I see a patient comes in and they've got a little zipper here from a knee replacement, they typically have quite significant disease below that level because they have to stretch those muscles out, and they frequently will be damaging those backup veins, those perforators. But those can be treated. Something else that we're becoming more aware of why people will have worse veins on one leg than the other is iliac vein compression syndrome, or May-Turner's was the original term. It's where the veins, once they all join up with the deep system at the groin, they combine in the pelvis, crossing over bony structures like the spine, left to right on the spine, and they can get compressed and cause abnormal back pressures down that leg, kind of like being a tourniquet, if you will. The symptoms are pretty much the same as those for vein disease, and you might ask, well, how do you differentiate them? If one leg is significantly worse than the other, particularly the left leg, because that's the side that May-Turner's is, because it has to cross over the spine with a high-pressure artery in front of it, that would raise our suspicion that the symptoms are really more than just broken valves of the skin of the legs. So we have low blood pressure from way down here in the veins that needs to get back to the heart somehow. There's not another heart down there pumping the blood back towards the heart. So the way the body does that is with walking and exercising. With good flexion of the knee and ankle, muscles push against the skin, cause the blood to go through a one-way valve. Now, most people have at least 5 long veins of the skin. The longest one is the greater saphenous vein. It goes from by the ankle up to the groin, where it then goes deep to the skin, joining up with the deep venous system. That greater saphenous vein, we're told, has 24 valves along its course. So as we're walking and exercising, that blood is inching its way back towards the heart. Most of us aren't walking or exercising all day, are we? Most of us, with our jobs and lifestyle, we're either sitting or standing all day. And so over the years, the blood builds up in those veins of the skin and stretch them out, and they stretch them out to the point where the valves fail. And when the valves break, they are broken the rest of your life. There's no repairing those valves. That vein is now damaged and it's not functioning anymore. The blood has to get back to the heart somehow. So fortunately, we're born with what I call the backup vein. The official term is perforator vein. Now, they're called perforator veins because anatomists many, many decades ago would take a look during one of their autopsies, and they would see all these little veins going from the skin directly into the muscle, and they were perforating the fascial plane between the skin and the muscle. That's why they're called perforator veins, but for ease of use, I'll probably be ending up calling it the backup veins. And we've got dozens on each leg. So once the blood goes through these backup veins, it goes into the deep venous system. Now, the deep venous system are the veins of the muscle, not of the skin. And so they also have valves. It's also low pressure, and they work much the same way, but we don't have to have such extreme flexion in the knee and ankle to push the blood up those veins. Just a little bit of rocking you see us doing here, or the movement that we're doing during the day pumps the blood up those deep veins, and for most people, those deep vein valves function the rest of their lives. One big exception to that is if people get deep vein clots. If they're not aggressively treated to dissolve, they can start to scar down the valves of the deep venous system, and then that could lead to something called post-thrombotic syndrome, which is at a very advanced level of vein disease with discoloration and damage of the skin and even open wounds called ulcers. And as many of you probably already know, deep vein clots are considered urgent to treat because they could potentially break free and go to the heart, be pumped into the lungs, and cause a pulmonary embolism. Now, as I described previously, the valves break, the blood's not going up those long veins, and the blood ends up going into deep veins. And you might say, well, if we got that backup system functioning, why are we treating these broken veins? The reason is those 24 valves along the greater saphenous vein break those long veins into short little compartments or little tubes. And short tubes have low pressure, and as we talked about, veins need to be low pressure for good circulation. But when they break, pop, 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 now you have a vein that's up to 24 times longer and significantly higher pressures down by the ankle, because it's just a big long tube. Think about it like when we measure blood pressure, we talk about millimeters of mercury in a long glass tube. Well, the higher that number, the higher those pressures. So that's essentially what's happening. These abnormal high pressures are going down those long veins, distributing to the branches, which can cause the varicoses. Again, only about 20% of people see the varicoses because they're deeper in skin surface, and can cause the symptoms of swelling, heaviness, tired, itching, burning pain, cramps at night, restless leg numbness. Some people have one or two symptoms, sometimes more. Eventually, those abnormal veins make those backup veins, the perforator veins, get bigger and bigger until their valves break. And many times that's when people really start to recognize their symptoms, is when those backup veins start to break enough of them, it can lead to permanent skin changes and open wounds called ulcers. And the process of treating those are essentially to close off those broken valves along those non-functioning long veins. It stops those abnormal pressures that cause those symptoms, stop causing varicoses, and stop damaging those backup veins. Now, we only treat veins whose valves are completely kaput. There's some people, they still have 25-30% of the function of those veins. We don't treat those veins. We let them become completely kaput, and only at that time do we treat them. This is essentially how those valves function. I mentioned to you, as we walk and exercise, muscles push against the skin, the blood goes from valve to valve until it gets back towards the heart. And for the number of reasons I mentioned, when the valves break, the blood's not going up in those long veins, so it ends up going through perforator veins. So the long vein on the left describes a superficial vein or a vein of the skin. The vein on the right of that double H is the deep veins of the muscle, and then the middle of those H's are the backup veins or the perforator veins. And as I mentioned, when the valves of the long veins of the skin break, that would be the long one on the left side there, it causes abnormal high pressures that can make the backup veins get bigger and bigger until their valves break, and that's what's demonstrated on that lower horizontal vein that you see on the H. So we talked about the different symptoms, and I've pretty much covered all of those except for the bleeding. As I mentioned, with these broken long veins, the pressures get worse and worse as we get down towards the ankle and foot. And at the level of the ankle and foot, the skin is very thin there. And these veins, when they become varicose, get very large, sometimes aneurysmal, and frequently the vein will fuse to the skin. Patients will go into the shower, and the water on that fused vein will become itchy, and they'll absentmindedly go down there and scratch at it, and they'll break it open, and then the shower is full of blood. They don't know exactly how to get that to stop, so they find themselves in the ER. Okay, I'd like to show the SEEP classification that we have. It goes from 1 to 6, and if you take a look at the SEEP classification 2, under simple varicoses, you see there are some very large bulging veins over there. Many times my patients will look at that and say, oh my goodness, that's got to be the worst vein disease, because look how big those veins are. That's class 2 out of 6. If you take a look at class 3, it's quite a bit of swelling, and then class 4 is skin pigmentation changes, and then on to 6 with open venous ulcers. That's those other levels are much, much worse disease. So if you take a look at those pictures of class 3, class 4, 5, and 6, it's very difficult to see any varicoses there. And I suggest to you that the reason you don't see the varicoses is patients didn't see them. Again, 80% of people typically don't see varicose veins. They had the symptoms of vein disease, but they thought they couldn't possibly have vein disease, so they didn't come get treated, and so it just got worse and worse and worse until open wounds. Once open wounds happen, the vast majority of those main skin veins are damaged. We try to get patients treated before it gets to permanent skin changes up on C classification 4. And so again, you'll hear me repeat this over and over and over again, the symptoms of swelling, heaviness, tired, itching, burning, pain, cramps at night and restless leg, numbness. Some people have 1 or 2 symptoms, sometimes more, but that's what we should be focusing in on, not whether we see a varicose vein or not. There are some things that would lead us to believe that maybe you also have the celiac vein compression syndrome. One, if you have a history of deep vein clots, it's possible that you have deep vein clots because of abnormal compression of veins in the pelvis. If one leg is much worse than the other, particularly the left leg, that raises our suspicion. And then there's something called venous claudication, and essentially that involves weakness, trying to just get up and out of a chair or climbing stairs. When we have that type of a history, we suspect that iliac vein compression may be happening, because we typically don't see that with the garden variety venous insufficiency. Let's talk about the different treatments now. The conservative treatment we talked about: exercise, maintain low weight, elevate your feet, wear the compression stockings to your level of comfort. As you all know, when you first come to see us, we put you into some compression stockings. Now, it's not because I hate you that I want you to suffer with compression stockings. I do it because every insurance requires us to at least try compression stockings with everything else of conservative treatment. Everybody's legs are sized and shaped a little bit differently. Compression stockings need to be high pressure, medium pressure, low pressure to help put the fluid up. When you put them on, what you want to make sure is they don't roll down. If you have knee highs and you pull them up to the knee, they're going to roll down. And just since I rolled that down, that's double the compression. Now it's high pressure, medium pressure, high pressure. It's like a tourniquet, and I feel my foot already swelling. If that's going on, it's best to put those compression stockings away, because we don't want, it could potentially do more harm than good. Compression stockings are there to give you a symptom relief. They don't fix or repair anything. When it goes on to time for procedures, radio frequency is a type of thermal treatment which will replace a catheter inside the vein just above the ankle, run it to the groin. We inject local anesthetic all around the outside of the vein to keep everything nice and cool surrounding that vein, and then using radio frequency waves, we treat 10 centimeter sections all the way down that vein. I get very good results with radio frequency, and it's my preferred method of doing thermal ablation. And the reason is there's a thermostatically controlled feedback loop, and it keeps the same temperature throughout the entire treatment time. Laser is quite variable. It could be too high, it could be too low. I frequently see patients who've had their long veins treated with laser, and they'll have a segment treated, a non-treated segment treated, not treated, and at that point it's very difficult to go in and treat those small little sections. So it's best just to do it with high likelihood of success at the beginning, and that's why I choose radio frequency. Laser sounds sexy, but in veins, it isn't. Now, that's not to say I don't do any laser. You know those short little backup veins, the perforators I talked about, they're only about that long? That's what's best for laser, because the radio frequency is a much longer treatment thing, and so laser treats those backup veins, the broken backup veins, perforators. From my perspective, it's the only way to treat it. Now, some patients will have these big bulgy veins right under the skin, looks like a snake under there. Those patients, at the same time we're treating with radio frequency, we'll inject local anesthetic around the outside of that vein, make tiny little 4mm incisions, and use something that looks like a $300 crochet hook to pull those veins out. It sounds kind of gruesome, but it's very effective. This is pretty much the same method of entering the vein just above the ankle, bringing it up to the groin, but instead of injecting local anesthetic or heating up that vein at all, we just put tiny little micro droplets of adhesive along that vein to turn off those broken valves. It works very well. It's very effective. It's how I've been treated, how most of my employees want to be treated. It is under protection of a patent, and so it is a bit more expensive. There's probably about 50% of the insurances that don't cover the venous seal and require us to treat with a radio frequency. But whenever we're able to treat with venous seal, that's my preference, because I know patients will be happier with it. So this is a diagram of showing how that radio frequency happens. It's a 10 centimeter long segment, and every 10 centimeters we pull it out after a treatment, and it does a very good job. It's been around since the year 2000. And you say, boy, that sounds like really old technology. It really isn't, and it's been improved upon over the past 26 years. So it's not like it's the same catheter that came out in 2000. VenaSeal, this is with the adhesive that I described, and it's how I've been treated. Besides whether insurance lets us use this or not, there's other reasons we might not do it. If somebody has a autoimmune disease such as lupus, or they have sensitivity to adhesives, we'll just go on and use the radio frequency for those patients. The recovery is pretty quick. In fact, the company tells us we don't need to even wear compression stockings immediately after the treatment like we do with radio frequency. We were one of the first clinics in the country to be doing VenaSeal, and they came and they videotaped this. So you're going to see a lot of people in the procedure room on the patient, who happens to be my brother-in-law that I treated with us, and he went right back to work immediately after his treatment. Draft003. This is one that I'd skip because it's a little bit different. I like to use it in veins that are veins that we can't get a catheter through. So if you've ever been to a children's party and you see the clown there making balloon animals and swords for the kids, they start off with a balloon about this long and flat like that, and they blow it up, and not only gets big and round like this, it's like 10 feet long, right? Well, their legs aren't that long, and that's why those veins become kind of twisty like that. This is similar to really, really expensive sclerotherapy. Comes in a very expensive canister like that. Makes very tiny microbubble foam, which the smaller the bubbles, the more effective this is. And so we draw it up into a syringe, and we will inject it through a needle into the vein and work it through that vein. And it irritates that vein well enough that it makes the vein wall sticky, and the vein closes down. Most of my patients will actually tell me once I finish, they'll say, "What? That was too fast. I didn't feel anything." Okay, we talked about May-Turner syndrome. We can actually treat May-Turners. Now that looks kind of busy up there, that design. The blue vessels are the equivalent to the veins, and the red is the high pressure arteries. And it says we're looking at the patient. So the left's on the right and right's on the left. And so on the right side of the image, that's the left side where May-Turner's comes across. Now those two images you see below there are screenshots of a video intravenous ultrasound. We place a catheter in a small vein of the neck, and we can come down and we can examine both the right and left side and with a video imaging, and we can find out where there's areas of abnormal compression. On the left, you see two circles that are outlined there in green. On the right, there's two, but you can barely see the second one because it is being compressed down. Again, I like to call this radiology right. It says we're looking at the patient, so the image on the right is actually the left vein. Okay, so this is more focused in, as I mentioned to you. Again, right's on the left, left's on the right. The pinkish vessel is the artery, and the gray-blue one is the vein. As you can see, as the vessels come out of the legs and through the pelvis, there's certain areas where they cross under these high-pressure arteries, and they can get compressed. The image on the right is an image that would describe it if we did a CAT scan. We did essentially a slice through the L5 level and turned it on its side, and we're looking at it, and you can see the vein pinched by artery. It's actually pinched between the spine and the artery that lies in front of it. As we get older, we start to get degenerative disease of the spine, and so as we get to degenerative disease, there's osteophytes that come out at the level of L4, L5, L5S1, and those osteophytes can not only come back here and pinch off the areas where the nerve roots are coming out and cause sciatica, they can also push forward and make this May-Turner's or iliac vein compression much worse. So this is some video of the IVUS that we do, and you can see before we stented, there's areas where you can't even see the vein, and then there's other areas where it's normal until we come along and place a stent, and you can see the post-stenting images along the bottom there. Besides doing the IVUS, we will also do fluoroscopy. It's essentially video x-rays. This was one of my first patients that I had stented, and described to me that the stenting of these abnormal compression areas had changed her life. She suffered from lupus, fibromyalgia, and she actually has given us a testimonial. She had quite a bit of symptoms going on there, and I would say the majority of the patients that have this disease, they have some other issues going on and not so much pain, not 10 out of 10 pain. I suspect that it's because of her fibromyalgia and lupus that everything kind of added up to make things so much worse for her. She's on her feet all day long. She's actually a pharmacy tech on the west side. Besides giving incredible symptom relief for patients who suffer from this, it can help to reduce the risk of deep vein clots, and which can lead to life-threatening pulmonary embolism. I think I've mentioned arterial disease. We do treat that here. I would say for every 200 patients that I treat for veins, I'm treating arteries, because vein disease is affecting so many more patients than the arterial disease. And this is a really old list about all the different things that we do here to be able to fully address patients' symptoms. Now these are the frequently asked questions. I've had a patient come in 2 days after her treatments, and she's got this big varicosity running down her shin. And she said, "Doctor, I didn't have that vein before you treated me 2 days ago. Now I do. You gave that vein to me." Well, as I mentioned, veins generally go straight, right? They may branch and such like this, but they don't do this. The reason she thought that I gave her that vein is because she had quite a bit of swelling, and after I treated her, swelling went away and it unmasked the vein that the swelling was hiding. That varicosity she had probably been there for at least 20, 30 years. I had a similar patient a few years after that who came in, and she told me I gave her cankles. Cankles are these fatty deposits around the ankles that we get as we get older, and she didn't see that she had fatty deposits because she had so much swelling. It was just like one big wooden tree there. We treated her, the swelling went away. Now she sees her cankles, and she's very upset that I gave her cankles. So the other thing I wanted to mention is the patient with that twisty vein, I assured her that we can do sclerotherapy, injecting a foam to make that vein go away if it bothers her. But for the cankles, there's really nothing we can do. Some patients will say, well, I only have symptoms in one leg. What are you talking about treating 2 legs? Occasionally happens where patients insist they only want the left leg treated. We'll treat that left leg. They come back a couple weeks later and say, I don't know what you did, but you made my right leg worse now. So if you have any symptoms on that other leg, it's helpful to be able to treat both legs along the same time, because there's times when there's shorter veins where we can treat veins on both the right and left leg all in the same day, and it saves both the insurance company and our patients money. Some patients will say, you get really busy here in your waiting room in the summertime. What's that about? Everybody out of school? Well, it's probably more to do with how veins act in the summer compared to the winter. In wintertime, veins have a tendency to shrink, and those valves get pulled together, and the pressure, abnormal pressures aren't so bad, so the symptoms aren't bad. When summertime comes along, things get much worse. And that's why in the springtime, I'll actually give this presentation to doctors in the community, because I know that they're going to see patients in the coming months. Many patients still don't get that understanding of why it is that we can essentially take these veins out of the circulation and somehow improve the circulation. And the reason being, they aren't really aiding anything in the circulation. They're just causing abnormal pressures that are damaging and causing symptoms, the other parts of the venous system, and causing the symptoms. Remember, I talked for good circulation, we need high arterial pressure, low venous pressures to push the blood cells through the capillaries. With those broken valves of those veins, the pressures come up and cause all those symptoms, and can eventually start damaging backup veins to where there's not enough blood flow, and then open wounds start, ulcers. By treating the veins, we bring those pressures back down closer to what's more normal, relieving those symptoms, stop damaging those other veins. Some patients wonder why they should get treated if they're only going to return. The vein treatments are like 90% or better effective, and if they're not, then we can go ahead and treat that vein. Would mostly What most likely happens to patients is, let's say when we treat them, it's only the greater saphenous vein. The other veins may be partially damaged, but still functioning, we leave them alone. But once they become damaged, then they start to causing symptoms to come back, and that's when we start treating those other veins. It's not wise to treat all the veins that could possibly be broken, because the body needs to start developing using those backup veins, and those backup veins really don't kick in until after these long veins are completely damaged. So we don't treat all the veins all at once, we just treat the ones that are completely kaput. I use a lot of analogies, and one of the ones I like for this is to describe the tires on your car. If you have 50% tread still on those tires, you're not going to replace them or take them off. But once they're bald, you kind of want to get them off before you start ruining your rims. This other one, I don't see varicose veins. How can I have this disease? Because only about 1/5 of the patients will actually see varicose veins. What can I do to keep my other veins from being damaged? The things that we talked about earlier for conservative treatment. Exercise, maintain the weight, elevate your feet. Perhaps one of the best types of exercises is water aerobics. As you're standing in the water, it's high pressure, medium pressure, low pressure. Every millimeter up, it's less pressure. Between the muscle movement of the exercise and the pressures pushing the fluid back up, it's very helpful, particularly for patients with lymphedema. If you have access to a pool, you should think about doing it. Don't jump in a hot pool or hot tub, because that's just going to make the veins dilate up. It's got to be, a pool that's at the appropriate swimming temperature.